Welcome, everybody. I'm David Dworkin, President and CEO of the National Housing Conference. And thank you to NeighborWorks for sponsoring this exciting series of events. We look forward to working with you all throughout 2022 to put on informative and popular webinars like this one. And thank you to Sandra Serna at SAFE for agreeing to moderate. We have an impressive list of panelists today to discuss an extremely important and topical issue, especially as we continue battling the COVID-19 pandemic. Long before the pandemic, we knew that health outcomes were inextricably linked with housing conditions. There is ample research proving, that certain diseases and chronic health issues can be alleviated by safe, decent, affordable housing. There are the obvious links that are known even to non-housers, like risks of lead poisoning, pests, and environmental risks such as mold and lead and air quality. But as housers, we know that the links run far deeper than this. Healthy housing impacts brain development in children and the physical, mental, and economic health of residents. Aging in place can make incredible differences in the lives of elderly citizens. Housers now consider everything from building materials used to create shade in the summer when thinking about healthy neighborhoods. Health and housing are also both contributors to the cycle of poverty, and addressing these two issues concurrently can help alleviate poverty and promote equitable community development. In 2019, NHC published a report on promising health and housing collaborations. We have much more work to do. Today, we will hear from experts in the field working to promote better health and housing outcomes at the local, state, and national level. We'll also hear about the virtual importance of partnership and collaboration in breaking down the silos between the industries, whether through data sharing, financial alliances, or simply building relationships. So that's enough out of me. Let's learn something more about health and housing.
Hi, everyone, and welcome. I'm Sandra Segunda. I'm the Vice President of Health and Housing at Stewards of Affordable Housing for the Future, also known as SAFE. SAFE is a national collaborative of 13 multi-state nonprofit affordable housing providers. Our work is mission-driven and practice-based. And we've been thinking about the health and housing space for quite some time, not just when it comes to access, but also thinking about connecting residents in a systematic and coordinated way through resident services to the other social determinants of health. The people you'll hear from today, Romi from NeighborWorks America, Colleen Flynn from Building Healthy Places Network, Andy McMahon from UnitedHealthcare, and George Sanders from New Directions Housing Corporation are all representing critical partners to many of SAFE's members and our work in the health and housing space. And at this time, when we have an unprecedented investment in many of the issues we care about, from energy and climate change to housing stability, health and public health infrastructure, with the American Rescue Plan and hopefully maybe other funding in the horizon, we have a new opportunity to think about the work we're doing in new and innovative ways. And so I'm really excited to hear from our panelists today, and I know we're going to have an exciting panel. So without further ado, I'm going to kick it off to Colleen Flynn.
Thanks, Sandra. Appreciate the introduction. Hi, everyone. I'm really excited to be here today. My name is Colleen Flynn, and I'm the Senior Director of National Programs with Build Healthy Places Network. Next slide. I wanted to go over a little bit about our mission. We're a national center who aims to advance collaboration between community development and healthcare. And the reason why this work is so important right now is that the enormous level that we're spending on US healthcare has really failed to redress the impact caused by root causes of health disparities, namely thinking about poverty, policies, and practices that perpetuate systematic racism. So what we're trying to do is promote racial equity and increase momentum for coordinated systems change through advancing collaboration between health partnerships and community development to think about more effective co-investment in affordable housing. Next slide. So the way that we think about it, as I was saying, is kind of where we are is we have a lot of poor health outcomes, a lot of racial inequities. And so far, there's been a lot of patchwork done and working in silos. And so what we want to try to do is thinking about leveraging assets, framing opportunities for strategic engagement, for co-investment and collaboration, so that we can think about building equitable, healthy, and safe neighborhoods that have affordable housing that's stable, safe, quality, and affordable. Next slide. So I think one thing that's important that I know a lot of you have probably heard about is we've come to this work really recognizing that health happens in neighborhoods. There's a ton of research that tells us that the zip code you live in is more important than your genetic code in determining your health. We can see that there are strategies for community impact rooted in place-based approaches and thinking about affordable housing in your different regions. Next slide. So one thing that we think about as well is that we found it useful to kind of distinguish between investments in clinical needs, social needs, and investments in social determinants of health. So clinical needs might be thought of as downstream investments that are focused on medical care. Social needs also focus on critical needs that generally fall outside of medical care. You think of going to the doctor office, being screened for food, economic and housing security, being connected to services such as social workers or community health workers. Those are all thinking about kind of the downstream measures and not necessarily addressing more of the root causes. What we want to try to think about is upstream investments, because these investments really do address social determinants of health and tend to aim at to prevent those downstream impacts that have people seeking healthcare. So investing in social determinants in health improves community conditions, takes shapes as policy levers, investments in holistic community well-being, systems approaches to change, think about housing, education, economic systems that impacts the health of communities. Next slide. And by our conservative estimates, the healthcare sector right now spends about $1 trillion annually treating preventable conditions that are caused by poverty, from folks that enter into the emergency room multiple times, suffering from preventable chronic conditions. And these conditions are obviously overrepresented in low-income neighborhoods, predominantly people of color, where patients lack stable, affordable housing, access to healthcare, education, collectively the social determinants of health. And healthcare is beginning to establish pathways to connect individuals to services to address these social needs. But despite their outsized influence on patient experience, costs, and health, the community conditions and systems that impending health still remain largely fall outside of healthcare's control. And it can be daunting in terms of capacity needed to address them. Next slide. So the real opportunity we see is that by both unlocking those dollars to address social determinants of health and establishing ready partnerships in those investments like affordable housing developers, community development partners. So we ask this question: how can we change the calculation to invest more deeply in social determinants of health? What is happening in the healthcare sector that presents motivators or pain points? And how can we position affordable housing developers to capitalize on those opportunities to create healthier communities? Next slide. And for us, there are multiple reasons why those health systems might be interested in investing further in social determinants of health to advance health and racial equity. This is a long list of kind of the table of what we think about. Some of those motivators are the IRS now requires nonprofit hospitals to invest in community benefit, and this is in many cases underutilized for community health investments. Further, we know that hospitals, health plans, and managed care plans have significant interest in reducing costs, particularly as they relate to emergency room visits and the cost of chronic care that is preventable. We know that many systems, such as hospitals, public systems, university systems, often have land or property that needs to be redeveloped. Or in some cases, they are purchasing new property for health services that could also be served as co-locating with affordable housing. These systems are also often rooted in place, known as anchor institutions, meaning there's rationale for hospitals and healthcare systems to procure services, goods locally, hire locally, invest in the economic development of a place. Many hospitals are also mission-driven, so alignment on values, vision is an important lens. And as we discussed, a lot of hospitals are addressing some of the social needs through things like community health workers and co-location. And so we're getting there to try to move further upstream. And then finally, there's new payment models that place value on well-being of people rather than paying for more services. And these are continuing to take shape. Next slide. So I wanted to share a couple of examples from the field. This is something that we do at Build Healthy Places Network. We have a lot of tools and resources on our website. Next slide. And one of them, we can go to, I think it's the other way. Stamford, Connecticut. So in this case, there's a housing authority that gave a site adjacent to the hospital for hospital-owned property elsewhere in the neighborhood. So the hospital was able to extend its campus, and the housing authority had space to build lower density mixed income housing somewhere else. But in addition, this collaboration planted a seed for a larger partnership of these two organizations for the entire West Side community with a central focus on health and well-being. So the Stamford Hospital helped create VITA, which is a beautiful mixed income housing with healthcare, a lot of thriving businesses, and a communal urban farm. And the total investment was $186 million that went to this mixed-use neighborhood revitalization project, an additional $450 million for hospital expansion. And the Housing Authority was able to create almost 400 units of affordable housing in the community as well. Next slide. So this is just a picture of how the community looks to date. Next slide. So what I wanted to share too is just some of the role of the Community Development Corporation. They were involved in the Housing Authority and trying to think about ways to replace the public housing, thinking about capacity building and financial resources and community needs. And then they provided the land swap to make this happen. And as we talked about, some of the motivators of the health system was they were looking to extend their hospital campus. They had a vision and commitment to population health, and they were thinking about additional programs and services they could provide to the neighborhood, thinking about their anchor institution role that we talked about earlier. Next slide. The second example I wanted to share takes us down to Orlando, Florida, where Advent Health, Orlando Health, and Florida Blue helped to catalyze the Lift Orlando Impact Investment Fund that raised nearly $10 million and deployed over $4 million in real estate acquisitions that included 7 properties over about 4 acres of land. And the health systems partnered with with West Lakes to make this happen on a various different set of projects. And one project was a 30,000 square foot, 200 mixed income apartment homes, which includes 120 senior units, an early learning center, a park, open space, a community wellness center, a cafe, community cafe, financial well-being center, community offices, fitness facility. Next slide. So I wanted to share a little bit about these 3 systems, why they came together for this project and found alignment between their missions is that they leveraged important roles as leaders in the project and the co-design and co-investments, and saw an opportunity to co-load these services together to have greater impact for the community. And the other part where they collaborated is they also contributed to data, which is a key opportunity that health systems can offer these types of projects to really understand the needs of the local communities. And the community partner and the affordable housing developer brought the community vision to the forefront, community voice, and a commitment to hold the vision for thinking about social connectedness and health, which propelled this project further. Next slide. So with that, I want to turn it over. Again, this is how you can find us at Build Healthy Places Network, and I have my email address in case you'd like to talk further. And with that, I'd like to turn it over to Romi Hall from NeighborWorks America. Romi?
Thank you so much, Colleen. Good morning, everyone. I am Romi Hall, and I'm the Director of Healthy Homes and Communities at NeighborWorks America. I'm so pleased to be with you today and share with you how NeighborWorks and our network bridge the gap between health and housing. Next slide, please. If you haven't encountered NeighborWorks America, we are a congressionally chartered network-based organization with nearly 250 affiliate organizations in every state, the District of Columbia, and Puerto Rico. Our work creates opportunities for people to live in affordable homes, improve their lives, and strengthen communities. While our network is largely known for its work of creating new homeowners, increasing the affordable housing supply, rehabilitating housing units, and robust training, you may not have known that our network is also doing incredible work to advance health in their communities. Next slide. While many may think of our network started to bridge health and housing recently in COVID-19, our network has actually been incubating and pioneering work at this intersection for quite some time. We recently implemented a network-wide health survey, and while we are still tabulating results, we learned based on the network self-report that nearly 70% of our network is implementing some kind of activity or work at the intersection of health, housing, and community development, with nearly 35% of our network having formalized health strategies in their strategic plans. This is fairly significant and indicates that our network is crossing the bridge to health. In addition to the network's health work, network organizations really stepped up their health and community response work during COVID-19. Over the course of the COVID-19 pandemic, our network has provided crucial response work in their communities to ensure that residents stay healthy, safe, housed, and can meet other basic needs. Some of the highlights of their work include providing rental resilience funds, to bringing vaccination clinics on site to their affordable housing properties, and organizing new food pantries and hosting PPE drives. Next slide. To further support our network to bridge health and housing, NeighborWorks established the Healthy Homes and Community Initiative nearly 10 years ago. Our initiative supports our network to advance their health and housing work with pilot projects and demonstrations, grants, training, and technical assistance. And we also build the capacity of our network to create health partnerships, measure the impact and outcomes of their health work, integrate health into their existing programs, and secure grant and capital investments. Next slide. The Healthy Homes and Communities work at NeighborWorks does not stand alone. The work fits into a larger container of work at NeighborWorks that is called comprehensive community development. Comprehensive community development is an approach that combines a focus on people, places, and systems to create a thriving, inclusive environment that supports the core needs of individuals and families. A number of strategies can underline a comprehensive community development approach, including health. Though what is key and core to this work is how comprehensive community development work must be intentional, must be equitable and inclusive, that it drives partnership, and what I would say is most critical, the work is community driven. Next slide. One of the ways our network bridges health and housing is through their comprehensive community development work, and specifically their work on resident leadership and engagement. Through cultivating resident leadership and implementing resident engagement strategies, our network can unearth and articulate why their community is experiencing inequities, identify strategies to address these inequities, and then take the actions needed to reduce inequities and create better opportunities. This very work is the foundation of not only advancing health, but also health equity. Health equity is about making sure everyone has a fair and just opportunity to be as healthy as possible. But it doesn't just happen naturally. It takes thoughtful action. To achieve health equity, one's work must be intentionally focused on removing the obstacles to health, such as poverty and racism, and be keenly focused on creating opportunity and access through cultivating the voice and partnership of residents. NeighborWorks America's commitment to resident leadership and community engagement is rooted in our origins. Our history has taught us that residents are the best authorities on what makes their community thrive. This matters because resident engagement leads to more effective and lasting solutions, ongoing community investment, which are foundational conditions to creating and maintaining healthier, safer, and more vibrant communities. Next slide. At NeighborWorks, we are currently implementing 2 national strategies that build on our network's resident engagement, leadership, and comprehensive community development work, and are about dismantling barriers and creating lasting opportunity in community. One strategy is focused on individual residents and supporting their health through the community health worker model. This model comes from healthcare, which is about connecting residents with health liaisons who can then support residents navigate healthcare, behavioral health, and other systems that impact resident health and well-being. Our second strategy is about building the capacity of our network to build partnerships and engage in community investment conversations with the health sector to secure community and resident prioritized capital investments into affordable housing. As Colleen shared, the health sector, including health foundations, hospitals, and health payers or insurers, need partners to co-invest in community-desired solutions that improve the social determinants of health for residents. In both of these strategies, we are intentionally supporting our network to engage in their community of residents and partners, to name what are the barriers residents are experiencing around health in their own lives and in the wider community, and then equipped with this knowledge, we are building the skills and capacity of our network to engage and cultivate their health partners to secure grant and capital investments to implement the community health worker model and create or preserve affordable housing. Next slide. So in conclusion, we have learned a lot from our network over the years about bridging health and housing, and some of the key insights that we stay focused on in our healthy housing and communities work at NeighborWorks are residents are the heartbeat of this intersection. Our network often comes to this intersection of health and housing, not necessarily on their own or what the field might be framing, but actually through listening to the voice of residents. And because of the network's intentional focus and proximity to residents, they will often do what it takes, no matter what, to meet the needs and address the barriers of their community. This focus is also key to build and sustain the ongoing momentum needed to create healthier, more equitable communities. Because work at this intersection, it takes time. And last, one of the important roles our network plays at this intersection is that of an intermediary. Our network and their health and housing work are often bridging the different stakeholders, including residents, to take actions needed to improve health. They are also adept in attracting, managing, and deploying investments that are often very complex. And this skill set, plus the grounding of residents in this work, it's important to leveraging and catalyzing health opportunity in community. Next slide. Thank you so much, and I look forward to answering questions, and I'd like to pass the virtual stage over to Andy.
All right, I am trying to get on video, but it says, yes, there we go. All right, good afternoon. My name is Andy McMahon, and I'm Vice President for Health and Human Services here at UnitedHealthcare Community and State, which is the Medicaid portion of UnitedHealthcare. And we have 31 different health plans, including the District of Columbia and 31 states, providing healthcare to more than 7.5 million people across the country. So for the purposes of this conversation today, I'm going to highlight several of the core strategies we at UnitedHealthcare are, are employing to help better integrate health and housing and also to expand affordable housing opportunities across the country. So the 4 areas that I'm going to touch on today include what we're doing and what other managed care organizations can also do around policy and systems reform within Medicaid, talk about some of the community partnerships between housing and healthcare, talk a little bit about the investments we're making in affordable housing, and then just a little bit on our clinical model and medical approach, especially to supporting people experiencing homelessness. So first, on the area of Medicaid policy, as a couple of speakers have noted, there's actually been a lot of momentum and some progress, I would say, on the understanding of the intersection between health and housing for sure. But there certainly remains a number of challenges on the policy front in terms of being able to leverage Medicaid and use Medicaid dollars to pay for an array of SDOH interventions, some of which we are working on currently. But to highlight a few of those, so first is around tenancy supports. So in 2015, CMS, Center for Medicaid Medicare Services, issued guidance saying that tenancy sustaining supports, if you will, are billable to Medicaid, and that can include housing search, housing-based case management, et cetera. So these tenancy supports, states need to go to CMS to get a waiver approval to do that. But that is an area that we have been strong advocates with others, both in applying for the waivers and then executing on the waivers when we do them. Secondly, on policy, and one of the other speakers noted this as well, is around leveraging community health workers in on-site and providing on-site services in housing. In some states, but in many others not, CHWs, community health workers, the services they provide can be billable to Medicaid, and others they are not. So this is another policy area of advocacy for us, where we are looking to advocate for more and more states to allow community health workers the services they provide to be billable to Medicaid. And since it's largely a housing audience, just one note on the importance of that, and that is that depending on the state, somewhere between 85 and 87 cents of every dollar goes to pay for Medicaid billable services. It's called medical loss ratio, leaving the 12 to 15% for administrative and operating costs. So when we have things that are not billable to Medicaid, we can pay for some limited portion of those, but you're looking at a 12 or 15% of a sandbox that needs to cover all of our operations versus the 85 to 87% of dollars that are billable to Medicaid. So I cannot stress enough that the need for advocacy on this front around billing to Medicaid. The third issue and relates to this is some advocacy we are doing with others, both with CMS and a number of states, around kind of broader coding. And quite honestly, I know we're focused on housing today, but on food insecurity and being able to pay for medically tailored meals. And there are an array of SDOH efforts where we think there is a strong reason to be able to suggest and advocate that it should be considered a healthcare service for these individuals and therefore billable to Medicaid. I think David even mentioned at the outset, there's also some areas that are very direct around housing and what the housing stock looks like. We're involved in a number of initiatives in 4 or 5 different states around both lead abatement and addressing childhood asthma, and leveraging, at least in part, Medicaid to address some of those issues. And then finally, as a prior presenter talked about, the proliferation of value-based payment models. So where we are increasingly able to use Medicaid and pay for the value and the impact, and not just kind of literally the service unto itself. So those are just a handful of the efforts underway around Medicaid policy and where we're trying to kind of bridge that gap between health and housing around Medicaid policy. The second area I want to talk about, where we've made, I think, enormous progress, is around community partnerships. And I'm going to focus on our partnerships with public housing agencies and local continuums of care. Through our community, our UnitedHealthcare Catalyst Initiative, we now have partnerships with 10 different public housing agencies across the country, where we develop formal partnerships as well as formal data sharing agreements. And we are able to understand the overlap between people living in publicly assisted housing and people on Medicaid. The Cliff Notes version is, if you live in a state that expanded Medicaid, the overlap of that is somewhere between 85 to 92% of people living in publicly assisted housing also being eligible or on Medicaid, right? Creating enormous opportunities and synergies for jointly working together to address the needs of their residents and our members. And those data sharing agreements are invaluable to us because we are able to identify key population health and community health issues that are critical and that are having the greatest impact, negative impact on a public housing agency's residents, and then able to develop partnerships with them, not to solve every issue, but to help address some of those issues. I would also say that it's interesting because that data sharing also tells us then in 9 times out of 10, 90% of the residents go to 1 or 2 very federally qualified health centers as their primary care provider. And almost always the public housing agency and the FQHC partners do not know each other, even though they're serving thousands, literally of the same people. So we've been able to broker and develop partnerships so that federally qualified health centers can bring community health workers in or have clinicians or nurses on site at various times to support in, if it's actual public housing. And so there's enormous ability to unleash partnerships with federally qualified health centers and other health systems through this sort of data sharing. Similarly, we are partnering in several communities across the country, and we'll be doing hopefully at least a dozen more in 2022, partnering with local continuums of care. And I would say, particularly with the recent influx of federal funding from CARES and ARPA, there's increasingly, if you can find units, as we all know is a challenge, there's increasingly resources available to provide rental assistance to people experiencing homelessness. And we're creating partnerships and again, data sharing agreements so that we know if our members are in the coordinated entry list, when their name comes up and they get a voucher and then they go into either affordable or supportive housing, we can then immediately connect our community health worker and have them reach out to them so that together the continuum of care and or the city or county are providing the rental assistance to the individual. We're coming up alongside those partners and that individual, more importantly, and providing them and getting them the support and the behavioral and primary care they need. So those are, I think, a couple of really critical partnerships we have. We also, kind of on a related note, are working closely with the National Healthcare for the Homeless Council and a number of healthcare for the homeless agencies to try to get more and more folks off the streets and into housing. The final piece I'll mention is that United Health Group as an organization overall is also both expanding and diversifying our investment in both affordable and supportive housing. To date, we've invested a little over $500 million in affordable housing projects over the last roughly 10 years. I am proud to say and glad to see, Sandra, today that we, about a year and a half ago now, launched a partnership with SAFE on a $100 million health and housing equity fund, which I'm delighted to say has essentially closed out at almost 120 million in investments, and we're looking to expand those investments. So appreciate the opportunity to join you all today and hopefully gave you at least some perspective on the various strategies that we as Medicaid managed care are focused on to try to bridge that gap between housing and health. I think I'm turning it to George now. Thank you.
Well, thanks a lot, Andy. I appreciate that. Up to this point, we've really talked more at the national level, and what I want to do is talk about bridging the gap, health and housing at the local level within a specific market. Again, I'm George Sanders, and I'm the Chief Impact Officer at New Directions. Next slide. New Directions was founded 51 years ago at St. William Catholic Church to support the community needs for social justice and housing equity. Today, we're Louisville's 23rd largest nonprofit, a community development corporation focused on affordable housing and community building, with assets of slightly more than $42 million. At New Directions, our mission is to develop and maintain affordable housing in partnership with neighborhoods and other stakeholders. Despite our growth over the years, many of the issues that led to our founding 51 years ago are as pervasive and painful as ever. In fact, in 2020, Louisville became one of the epicenters of the nation's racial and social justice movement, fueled by the tragic killing of Breonna Taylor. Next slide. Today, the need for affordable housing in Louisville has reached crisis levels. By recent estimates, more than 31,000 units of affordable housing are needed just for those making 30% or less of area median income. And the COVID economy is exacerbating this problem with rising costs and flat incomes. Next slide. At New Directions, every day we see evidence that housing disparities are literally killing people. Although separated by less than 5 miles, the difference in average life expectancy between the West Louisville neighborhoods we serve and more affluent neighborhoods to the east is a chasm of 12 years. We looked at this data, and about 3 years ago, we asked ourselves, what can we do about it? Next slide. So we spent some time examining the New Directions lines of business and revealed 4 areas of opportunity that we felt could positively impact housing as a foundational social determinant of health: affordable rental housing, family self-sufficiency, childcare, and aging in place services. Next slide. While there is a critical need for more affordable units, it's clear we can't just build our way out of the housing crisis we face. So we look to strategies that would complement our production needs. In 2021, New Directions became Kentucky's first nonprofit to administer HUD's Family Self-Sufficiency Program. We launched the iRise program to enable families to break the cycle of poverty by charting a life plan of their own design to navigate them to essential supports required to achieve their goals. Just 1 year into this process, we're already seeing confirmation that iRise families are excited to work with a life coach who is helping support their educational and employment goals in a manner that avoids the benefits cliff. By the end of the year, we will have more than 300 families enrolled in iRise, allowing them to access the education and job training necessary to live independent of subsidized housing and eventually freeing up units for other families. This is exciting news, but I'd be remiss if I didn't emphasize that I am not suggesting that self-sufficiency, that iRise is an alternative to new housing units. At New Directions, we're unequivocal in saying we need both iRise and investments in new housing. Next slide. As important as it is to create more affordable housing units, funding will remain a significant impediment. After a multi-year financing development effort, New Directions will soon break ground on the Roosevelt Senior Living development funded via HUD 202 and dollars from local and state housing agencies. This project will create a multi-generational campus through the rehab of 47 existing units and new construction of 36 senior units. Next. New Directions has other projects in the planning pipeline, which will not just increase the number of units produced, but also create opportunities for self-sufficiency through the use of dedicated iRise staff. Nearly $200 million is being deployed for the mixed income redevelopment of HUD public housing in Louisville's Russell neighborhood. We plan to renovate 82 existing units and build up to 100 new iRise eligible apartments. When we talk to healthcare funders, it's more than bricks and sticks. We stress the importance of self-sufficiency, allowing those units to be used multiple times by different individuals as they progress through the development of self-sufficiency. Next slide. Access to quality and affordable childcare is essential for iRise parents. From a healthcare perspective, New Directions operates the St. Benedict Center for Early Childhood Education, located adjacent to our Brandeis apartment complex. Last year, we introduced free health and dental screenings for all the children enrolled in the program. In fact, not only did we offer it, we demanded it. We said, if you're going to bring your children, we want to ensure that they're having access to the health and dental support that they need as they progress to pre-K. And with nearly 1/3 of these children also exhibiting behavioral problems rooted in the parents' past issues with substance abuse or other in-home traumas, St. Benedict utilizes a part-time behavioral intervention specialist to support these children, and we're actively fundraising to make this a full-time role. Next slide. The fourth area of focus for our health and housing strategy is aging in place. In Kentucky, 1 in 3 seniors reported a fall in 2018, with 10 to 20% requiring hospitalization. The average treatment cost was $57,000, which totals $493 million over a 2-year period. We concluded, just looking at this data, that fall prevention and in-home health monitoring were important additions to our health and housing strategy. Next slide. So in response to these issues, we're partnering with Louisville's Thrive Center. The Thrive Center's mission is to promote healthy aging through technology innovations and specialized educational programs. Beginning this summer, residents at our St. John Senior Living Facility will participate in a trial in which they will be equipped with motion sensors, voice assistants, and wearables for fall detection. The program also includes technology-based exercise and strengthening activities. Our goal is to keep older adults active and to quickly detect falls or other needs for assistance. We plan to introduce the same technologies in the Roosevelt Senior Living Project that I mentioned earlier, but we'll take it a step further by incorporating smart appliances such as cool to touch range tops that also turn off when detecting excessive heat. Next slide. For 28 years, New Directions Repair Fair has provided free handyman level repairs to elderly homeowners. Repair projects such as trimming a fence row, exterior painting, minor plumbing and carpentry projects are installing lock sets, handrails, and grab bars. We use high-skilled volunteers to complete projects such as ADA compliant wheelchair ramps, and we hire professional building contractors for roofs, HVAC systems, and other high-end repairs. Last year, we completed our 4,000th repair, and we're really proud of it. But examining Repair Fair through a social determinant of health lens led us to a different conclusion. We recognize that providing the repairs to make the house sustainable for the homeowner was one thing, but helping that individual to live independently was another. And so we're partnering with Spalding University's occupational therapy program. Now, in addition to doing the structural repairs of the home, we send out an OT doctoral student to conduct an activities of daily living assessment, and we do other assessments as well. And from that, we establish a fall risk score for each homeowner. And then we develop a fall prevention plan, such as installing ramps, tub to shower conversions, or handrails and grab bar installations. After the work is done, the OT student returns to conduct a follow-up assessment to confirm the impact on fall risk. Through Aging in Place, we also assist older adults with estate planning, including preparing a last will and testament to ensure an orderly transfer of property, as well as a living will to ensure that their final wishes are being honored. Preliminary evidence suggests that this program can prevent falls at a fraction of the cost of medical treatment. with New Directions Aging in Place, while it's been, the Aging in Place program has been funded historically with philanthropic dollars, we're in discussions with 2 MCOs about the potential for a fee-for-service model. This would entail the MCOs actually using their own predictive models to identify individual members who are at high risk of falls, and then proactively making those referrals to New Directions AIP, Aging in Place, so that we could deploy our resources to try to make an intervention before the fall occurs. We're doing a lot of things and we're excited about what we're accomplishing, but we know there's much more to do on this front. And what we are committed to is a strategy that will allow us to not just depend on philanthropic dollars, but to partner with MCOs to take advantage of Medicare and Medicaid options for funding, so that we can do work that is going to provide a return on investment for the MCO. That's all that I've got today, so thank you.
Great. Thank you, George. And now, you've been hearing from our panelists. We have a lot of time, which is fantastic, to answer your questions. And we've been receiving them in the Q&A box. Encourage you to continue to contribute. And we'll go ahead and get started. So I think, we've heard from some national examples, very concrete on the ground examples of how these partnerships can bear fruit. But I think, let's start from the very beginning. Like, how have your organizations broken down these silos to work with healthcare and healthcare working, with housers? How, what motivates, from where you sit, your organization to reach out across and work with healthcare or housing, depending on where you sit, and vice versa? Anyone want to start with that?
Well, I'll start with that question. We've been aggressive at trying to make connections with healthcare providers. What we're also doing, our MCOs, we are also as I mentioned near the end there, is we're looking at opportunities to connect with healthcare providers in a way that is not exclusively based on philanthropic dollars, but it's again a fee-for-service model. There's still a lot of work to be done, because in some cases Medicare rules don't allow for funding of some of the kinds of programming that we're looking at. But I think that there's opportunities to make changes, and we're growing in that capacity. If we can prove that aging in place works, and I think that there's evidence already that it does work, then I think that there will be opportunities for us to be able to create additional partnerships with healthcare providers.
Yeah, and I'm happy to share as well. So I think there's a couple of things. So I think, we are, one of the things that I say to our 31 CEOs quite frequently is, we know that housing is healthcare. So now what are we doing differently about it? Because we know that, right? And so I think for us, I would say there are a couple of things going on, including the fact that we understand that both for our members and for other people in the community, if we make these systemic partnerships and create these partnerships across housing and healthcare, our members and the whole community will be better off for it. There's absolutely no doubt about it. So from our perspective, that is a major motivation for us. And so I think I can say quite candidly and genuinely that for UnitedHealthcare, we've been kind of going down this path for several years, as it is for quite a long time. That said, just so you all know, and everyone probably is aware, but we also our state Medicaid agencies, so every Medicaid managed care organization, has to submit RFPs to procure contracts to provide Medicaid in states where they do Medicaid managed care. And states are asking us also what we're doing. And so we also, MCOs are also have, I think appropriately so, higher expectations put on us by our state Medicaid agency partners as well. And there's a host of other things, but I'll stop there.
I can add as well. I think with Build Healthy Places Network, one thing we're seeing too is that a lot of healthcare systems, and if you look at Healthcare Anchor Network, another resource, have committed to anti-racist policies and partnerships and trying to advance racial equity. And so we see that as a lever for partnership ability with housers and community development practitioners in the field, is how can healthcare and community development come together to advance racial equity, and how can that be operationalized? Because there's a commitment, there's statements, and how can we come together? Because we feel like that's at the root causes of a lot of these health issues. If we think about poverty, systematic racism, policies. And so we really see that as a big lever in moving forward and how we can think about partnering together. And I think some of the silos happen too, because there's a lot of acronyms, there's a lot of complication in language. So one thing we try to do is think about how can we come up with shared language and actions and goals together to think about the health of a neighborhood and what would that look like. And thinking about, as Andy's mentioned and others too, there are some challenges with the current healthcare system and what's allowed as far as Medicaid and other resources. So it's also figuring out how we can change those policies to allow for more money to flow to what we really want to see is money flow directly to communities. So community-led efforts, community ownership models, and what that might look like. And I know in California right now, for instance, Governor Newsom in his budget proposal has suggested that 25% of community benefit money go towards social determinants of health and what that would look like. Because right now, a lot of it goes towards other services. And so with that change, there could be more ability for co-investment if some of that community benefit money could go more towards community-led efforts and community ownership models.
I just want to build an add-on to that. And I think the great work that George and New Directions is doing is that affordable housing and community development really sit as this intermediary role between community and the different stakeholders, and health. The social determinants of health can take a lot of different shape and forms. And so I think it's really understanding how affordable housing and community development is part of the umbrella of creating a healthy community and identifying those partners, residents are really prioritizing and moving forward. And so there's a lot of mission alignment in that social determinants of health and how you can advance, and having residents and different cross-sector partners and stakeholders that are really needed to achieve. It's a wicked problem.
Great. And, in the spirit, I think of, crossing bridges and building shared language, Colleen, if you don't mind, could I ask you to define community benefit for housers who may not be familiar with that? We did answer a similar question as to why hospitals are required by federal law to invest in community benefit. That's already been answered, but I figured, in the spirit of jargon busting, if Colleen, if you wouldn't mind.
Sure, and Andy, you can chime in here too. Essentially with the Affordable Care Act, it included different requirements for hospitals and healthcare systems. And one of those is to regularly complete and publish a community health needs assessment with the community, and then describe their resulting kind of in a community health improvement plan. And so with that, the ACA also allowed more flexibility for tax exempt nonprofit hospitals to meet their community benefit requirements through community building and community health expenditures. And so those can be used. A lot of times it ends up being, a lot of it is kind of social needs based. So again, it's not necessarily getting to the upstream measures. And there is a recent analysis that found that only 7% of community benefit spending nationally was directed in this way. So, I think that's why I think Governor Newsom's plan in California to increase that would be exceptional and a precedent that could be set. I think, as Andy also pointed out, there's hopefully increased Medicaid flexibility. There's some examples of that. The 115 demonstration waivers are potentially a promising avenue to explore, and happy to talk more people offline. There's an example in New York State, the Medicaid redesign team for supportive housing initiative, and others around the country.
Andy, did you want to add anything to that, or I can?
No, I think Colleen covered it. I think I would
Yeah.
just say in the jargon busting part, maybe I might just reiterate, because I do think hopefully I was reasonably articulate in explaining kind of that, we have 85 to 87% of the funding that we get from the state Medicaid agency goes to pay for Medicaid billable services. And the other, 12 to 15% is for administration and operations. And so we can usually find a little bit of money to do things that aren't billable to Medicaid. But we will never be able to scale any of those, right? Because we're looking at the tiny pot of money that's the admin pot, and where 85 to 87% of the funding is appropriately in the Medicaid pot. But that's where we all have to honestly put the oars in the water together and find ways to advocate with states to create more flexibilities in paying for some of these things. And hopefully I laid out a few of the ways that we can do that, but there's a host of others that we need to work together on.
Exactly. And it really does vary state by state. It's completely dictated by state policies. So,
yes, it's every state. Yeah. I know it's an old trope for anything, but it's like, if you know one state Medicaid agency, you know one state Medicaid agency. It's true in Medicaid for sure.
Absolutely. So we have an interesting question in terms of how do you guys approach the evaluation of health benefits and impact? So have any of your organizations, or any of those who are membership organizations, any of your members looked at the cost of interventions, and are we seeing healthcare savings?
So go ahead. No, I thought I was going to let my panel's friends talk about some of their initiatives and what they're seeing. I'm happy to chime in, but please go.
Sure. So one of the at NeighborWorks, we have a social enterprise called Success Measures, and we have a body of tools that are available to our network and others that is really has been incubated by our network in partnership also with enterprise community partners. The co-development of these tools were based on what our network was doing around health outcomes, and then developing measurement tools and having them engage with those tools and edit them, and then making them publicly available. In a couple of moments, I will drop in a link with a research paper on those health outcome tools and take a look at. And forthcoming, we have a virtual training institute the week of February 7th, where we're actually highlighting one of our network organizations, Reach Community Development Corporation in Portland, who have just come out with this study that really started to look at the evaluation of housing with services in affordable housing collaboration, where they partnered with an ACO and other their Portland Housing Authority around evaluating that success. So we'll be sharing more, and that more and more information is going to be coming out around that.
I also wanted to add that Build Healthy Places Network a couple of years back wrote a paper on thinking about a model for estimating the health returns for comprehensive community development that I can share with you. So it's getting into the ROI we were talking about. And there was a facility in DC, the Conway Project, that had housing for homeless people, a lot of health services, dental, senior housing, affordable housing. And the research that we did showed a over 300% rate of return for this type of comprehensive project in DC. And so it's showing kind of the health returns over the lifespan of the project. And then the other thing I was going to add, similar to Romi, is that we have a microsite on our website called Measure Up, and has a lot of resources and tools that help you measure and describe impact of your programs on families and communities. And some of the things that we do at the network is thinking about mapping your neighborhood too, and thinking about kind of what are the key indicators and what kind of change you would see over time. And one thing is also thinking about life expectancy and some of those other indicators.
In support of the New Directions iRise program, we're partnered with Unite Us, and they are one of their key strengths is their ability to identify social impact and quantify that. We're only a year into our programming on iRise, and so it's a little premature to be able to draw definitive conclusions at this point. But we're confident that when we come back a year from now, that we'll have some data that will say, yes, this is the quantifiable benefit from introducing a family into the iRise program.
Yeah, and I would mention just from the managed care perspective, I think there's a couple of key things that I would mention, and one of them won't be super popular, but I'll share it anyway. But so what I think there are some areas of opportunity for cost savings. I think it is very dependent on the target population, and I'll take an example that I know well around supportive housing. For our most complex care, most vulnerable, most expensive members, the answer is that it does have a return on investment to invest in their housing. But if you talk to our healthcare economics folks, for the overwhelming number of folks, that is not the case. And so I think we need to just be mindful of that. And so it's so critical how we do the targeting of those types of programs. And then, I think one of the challenges that I've been focused on here at UnitedHealthcare for almost 5 years, and prior working with many of you that are probably on the phone, is how we kind of address some of these wrong pocket questions, right? Of kind of funding going one way and coming out the other way. And I think, one of the biggest challenges that we have in healthcare, quite honestly, is that I think I think George, it was you mentioning you've run an amazing program and showed the offsets of kind of, hospitalizations that were reduced. 100% believe it and trust it. I think the challenge of that right is that those are costs that were not incurred though, right? You know what I mean? And so it's hard to monetize a cost that wasn't incurred in talking with financial folks on our end. And so that's just something I think, honestly, it's kind of like a challenge that we all have and hopefully can work on together going forward.
Great, thanks for that. So we're going to pivot a little bit, and someone here has a more of a policy question, and particularly aging in place. And George, you really spoke to that as quite a bit. But for the panelists, what would be the most important elements of a national policy that could address the needs of aging HUD residents? And how could we ensure, that would lead to better health? Anybody thought about that?
Can you say that one more time? I want to make sure I heard the question correctly. I was paying attention, sadly.
Well, in terms of when we think of policy opportunities, and aging in place, and just, making sure that, what do we have available?
Yep. Okay. Now I'm so I think so.
Yeah.
And I'll share a thought or two and hopefully I'll be working with you at SAFE and some of your members on these types of issues. I think this is where I would come back to two things, right? And I'm now talking about the residents themselves, not the aging of the buildings, right? Which is a challenge I know you all have as housers in terms of delayed maintenance, et cetera. So not touching on that part, but touching on the other part, I would Sandra and team go back to two things. One is promoting and advocating for on-site services that are provided by a community health worker that can be billed to Medicaid, right? Having lived in that world, right? Nobody pays for that, right? It's like the thing that everyone wants, everyone knows we need, and nobody says is theirs to pay for. And I say that across the board to all the stakeholders. And it usually doesn't have, when it does have, it's often not a sustainable ongoing source, right? And so Medicaid for community health workers would create that opportunity. The second thing I would mention that I didn't talk a whole lot about before, that I'm working on currently, but we have a road to go, to be honest, is around shared payment models for services. And so it's a complicated thing, but to say it in 20 seconds, hopefully, is the notion that if there's 100 unit, Sandra, if there's 100 unit, old HUD 202 building, and if we have 9 members in that housing, there's no way that it's sustainable for us to pay for on-site services, 7 days a week or whatever in that property. But if 2, 3, or 4 of my Medicaid partners, the other Medicaid managed care organizations, if I can create shared payment models with them, which I promise you I'm desperately trying to do, if I can work with them to do that, and one other MCO has 11 members, and then another one has 9, and a fourth has 12, now all of a sudden you could say, okay, well, everyone pay your pro rata share for on-site services. It'll make sense. It's viable for everyone. And then all of the residents benefit, right? So regardless, even the 4 plans, me and the 2 or 3 other plans, would pay for the on-site services, and all the residents would get them. So I think those are the 2 best, at least from where I sit, those are the 2 things that I'm focused on in terms of trying to address the challenge you're talking about.
I would just add that there are 10,000 people a day that turn 65. And from a policy perspective, it's clear that the number of those individuals that fall, that's an area of focus for us at New Directions. The number of those that fall is going to continue to increase. What we've got to decide is that, do we wait until we reach a point where it's unsustainable to be able to treat the number of falls that we're seeing, or do we try to impose some kind of intervention strategy today? So if I had the magic wand or the fairy dust, part of the policy change would be that we're going to invest heavily. Just as I mentioned in my presentation, there are options from a technology standpoint that could help, as well as investments in rehab. Average rehab will cost about $10,000 for fall prevention. So we want to make sure that we can find a way to be able to deliver preventative solutions, because we're going to see increases in treatment costs, because we're going to see increases in falls with the aging of the society.
Absolutely. I mean, and I'll just, quickly add that at SAFE, that's something we think a lot about. We have members who have 202 properties, but we're also thinking a lot about those members who have properties that, maybe the average age of the resident had been 65, and then, they're stably housed, which is what we want for them. They're connected to services, since 60% of our portfolio is serviced and rich housing. And so they stay in that home because it's affordable, it's stable, they're connected to services. And then before we know it, the average age of an occupant is, 80 something years old. And obviously the needs between, those folks are very different, and they don't have the designated 202 to assist with some of those costs. So that's something we're grappling with as well and thinking about. And we're always, I think similar to the community health worker coin, where we know that it's, community driven, it's peer-to-peer, which is so important. They already have that built-in trust with the folks they work with, similarly, resident services coordinators who are embedded in properties, we don't really have a sustainable funding mechanism for that either. They don't do exact similar things, but it's very interesting to me that the folks that really connect community members and do the warm handoff and are the connective tissue, we don't have an adequate way. So I think overall in a policy be better investment in not only CHWs but service coordination. For sure. I have a specific question for George. So they were one of the attendees asked, does the Roosevelt multi-generational campus include housing specific to grand families? Or more broadly, are there any new resources that you're leveraging to address the housing and healthcare needs of grand families and their unique family composition?
Yeah, okay. The project that we're undertaking for Roosevelt is a remodel of an existing number of units, which range from 1 bedroom to, I believe, 3 bedrooms. So they're typically family units. The new units are all supportive housing HUD 202 properties, so they will be for seniors. The intent is for us to develop a common space to allow intergenerational mixing between the residents of each of the properties. It's just across the parking lot, so there'll be some common space that will be included there as well. But we don't specifically at this point have a strategy for dealing with grandparents. So you have the senior in a unit, and then you have the children and the grandchildren in another unit. So that's not part of our current strategy.
Great, thank you for that, George. Colleen, we have a question for you. And you spoke about the mixed income units of the LIFT project, and they had questions about any of the projects you mentioned and that focus on advancing equity. How did marginalized groups and communities of color, are you tracking how they've actually benefited from the project? Could you speak a little more?
Sure, Sandra, happy to. I was looking up, I saw that question, I was looking up that example in Orlando, and we do have a case study, an essay that I just shared in the chat function. And I guess the answer is, we're a national center that helps to advance collaboration in the field. And so I don't have the details about that particular project. I know it is mixed income and they're providing housing solutions around that. That said, that project also is addressing chronic homelessness by creating affordable housing units for that population. They're also thinking a lot about creating employment opportunities for persistently marginalized communities and inclusive workforce development jobs, and thinking about career pathways. They have a wellness center and a food access center that thinks about creating opportunities for affordable, healthy food for people that have been in food insecure in the past. And then generally speaking, I think that is something that in the field we could do a better job of in general, is tracking results and evaluating success. One thing I did want to add is that at the network, we are centering all of our work to think about working with historically marginalized communities. And we have a new initiative coming out called Community Innovations for Racial Equity, where we'll work with BIPOC-led community development corporations to help advance collaboration with healthcare. George was a part of the first cohort, so he can talk to you a little bit about that as well. So that's a little bit more detail. Hopefully that was helpful.
Appreciate that. George, is there anything you wanted to add?
Yeah, I'll tell you, I thought that it was an extremely productive process for us. We learned how to really assess our readiness for a partnership with health providers. We were able to understand their language better. We were talking about speaking different languages with different acronyms, but we learned to be a little bit more bilingual. And so it was a very positive and productive process. I think it just facilitated for us how to make the pitch quick without and how to focus our pitch on things that are important to healthcare funders. So it was a very positive process for us.
And Sandra, if I could, I don't think you could overstate the importance of understanding and coming up with some shared common language that George is talking about. As somebody who spends part of every single day being an interpreter between housing and healthcare, right? There's just a whole set of jargon, right? When you guys say LIHTC, most people in healthcare have no clue. And when I say MLR, medical loss ratio, most of you probably don't know how all of those types of things, and we all use those, and that's our day-to-day nomenclature and how we operate. And so to George's point, he's exactly right. Like when we enter into these partnerships, you have to be more intentional about changing your own language and being open and learning another system's language.
And I was just going to add to that is that some of the things that we've been incubating and learning at NeighborWorks, we've done a lot of health partnership work, and I'll drop in a minute. We have a tool we mapped out with our network, the different stakeholders and the different roles that they play, as well as a glossary and Build Healthy Places network. We co-partnered around that resource. I think the other thing that took some time for in our work with our network around this particular health sector investment into capital investment in affordable housing is recognizing that taking time to build relationship is part of this infrastructure. It's like infrastructure. Building relationships is infrastructure building to lead to those larger investments and partnership opportunities and giving time. And I think, some of the other things we're learning is that some of our network organizations are like, oh yeah, we just go pitch to them like we go pitch to the bank, but it's not. It's really about finding those alignment and those opportunities where there's mission orientation, goals, and understanding how the interrelations happen that then produce these amazing results that George and Colleen alluded to, and Andy has shared in their interest of partnering with affordable housing and community development.
Absolutely. Oh, I'm sorry, Andy.
Well, I was just saying, just on that point around the relationships part, I think that's where, and I so appreciate David, you and your team and others convening this group, and I'm happy to come to the table any day of the week, including weekends, because I think, from where I sit, right, we've got to do this work. And the reality is, like Romi was talking about relationships, right? Like relationships don't scale themselves. You can't develop a partnership. Like relationships do not scale. They're the least scalable thing on the planet, probably. But if we can come together and create kind of common language and norms and those types of things around working together, then we can still dramatically accelerate our partnerships together.
Great. So we have 4 minutes left. Final question is more just in terms of your thoughts, when we think a lot about the American Rescue Plan and just some other, again, as each of you have mentioned, this unprecedented investment in all the work that we do and that we care about. And so what is one thing you would like to impart to attendees here in terms of that opportunity to funding, something that they should do or look forward to or consider?
I'll start. If you're working and providing housing assistance to people who have acute healthcare needs, please reach out and partner with us, but or any managed care organization, and try to develop that partnership so that as those folks get the rental assistance they need, we can come in alongside and help ensure that they're getting their primary and behavioral health needs and other needs met as well.
And I would just add that I think with COVID, one thing that we've noticed a trend in is that a lot more healthcare partners are thinking about stepping in and supporting policy change. There's been work on thinking about tenant protection, community land trusts, other types of policy solutions. And we wrote an article recently on how community land trusts, more hospitals are getting involved in that because so many places are becoming unaffordable and people can't stay where they've been living for a long time. There's a lot of displacement happening. So I think there's lots of trends towards healthcare really pulling their weight in advocacy because they have a lot of weight in the advocacy realm to support these types of policies and solutions.
The entitlement cities and the states are pretty far along in many cases with regard to submitting or releasing NOFAs for ARPA funding, and others are not. But whether you've seen a NOFA, you really need to be having conversation as much as possible with the state, with the municipality, to ensure that they understand it. They all understand the need of housing, but you need to really be making those connections in order to take advantage of potential funding that's is available.
And I think I would, as part of our strategic focus and our new strategic plan about with NeighborWorks is this intermediary role and backbone role that community development and affordable housing has. And because of the proximity in communities and neighborhoods and the relationships, I think that's a really key piece of how we are able to not only listen and then identify the partners that are needed to then move forward and address health is really critically important. And so that intermediary role, understanding that role and ability to be a convener, build those relationships and do that work is really critically crucial and needed at this time with unprecedented investment.
Great. Well, thank you all. And we are essentially right at time. So thanks for this lively discussion.